Warm welcome to the last lecture of our third IPNFA online congress. My name is Benedikt Böhmer and I'm a PNF senior instructor. It's a big honor for me to have the possibility to present my lecture today. The topic of my lecture is the treatment approach with PNF in patients with spasticity. And this is really a big topic. We can talk about this topic a couple of days. And that is the reason that I'm focused in my lecture today only with patient who has a lesion in the hemisphere. The content of my lecture is, at first we are looking, is there something new in the field of spasticity? Then we talk shortly about the upper motor neuron syndrome, and I want to inform you about the new term in the literature, the spastic movement disorder. Then I will show with some patient example the treatment approach, how we can use PNF with this kind of patient. And at the end I have a small conclusion. I hope you will enjoy my lecture.
Spasticity has traditionally been thought that hyperexcitable stretch reflex have a central role in the pathology and the clinical manifestation of the disorder, like you see it on my patient on the left side. With my patient, clonus, and an hyperreflexia of the patellar tendon reflex. And spasticity usually is defined as an exaggerated resistance of a muscle to a passive stretch, as you see it also with this example with my patient. I feel a lot of resistance against knee flexion. So that means it's not only the hyperexcitable stretch reflex, but also other neural and non-neural factors that contribute to a muscle resistance and muscle tone. We can say the hyperexcitable stretch reflexes are not responsible for the functional deficit following brain and spinal cord lesion. If you're looking one more time on my patient, if you remember, we saw him during my explanation about the definition about spasticity. This is huge hyperreflexia, the patellar tendon reflex, and also this clonus. In combination with this huge resistance against knee flexion, we can assume or we expect a huge extension spastic pattern of his left leg. Now, if you're looking on this patient, how he's coming from sit to stand, I go a little bit forward, quicker. And now, observe how he is coming from sit to stand. So he's not using an extension pattern when his leg goes in flexion. To understand now what are the reasons for the limitation on the activity level, we looking on the definition of the upper motor neuron syndrome. My favorite definition is this from Newman and Barker from 2012 because they highlight already in this definition what are one of the main problems after a lesion in the central nervous system. Here the features are weakness, postural instability, and spasticity. If you're looking also in the newer publication, the characteristics are the same: weakness, spasticity, clonus, and hyperreflexia. If you're looking further on in the literature, the main function problem after lesion in the central nervous system are the paresis and weak muscles. Secondary to the paresis, muscle atrophy developed and the muscle becomes weaker, which adds to the functional impairment. If muscles are weak and not easy to activate, joint stability and posture are threatened. And this is then the cause for this postural instability, what we heard in the definition of the upper motor neuron syndrome. Postural instability means we have to compensate somehow that we can move automatically against gravity force. So a strategy to compensate the postural instability involves co-contraction, the most optimal solution to minimize the degrees of freedom and create somehow a stable movement. Co-activation of antagonist muscle, stiff posture and gait may rather adaptation that aim to ensure joint and posture stability due to the insufficient muscle strength. So the central nervous system is looking for a strategy how I can move against gravity force or how I can stabilize myself against gravity force. Here an example. This is a patient after a traumatic brain injury with a hemiplegia on the right side. In standing on the left picture, you see almost he's looking quite normal. You can't see a big tonus production or pathological pattern. If you're looking how he's walking, you see directly he starts with an associated direction in the upper extremity, he's looking downwards, and he's keeping the leg more or less in flexion. So then you see in this picture on the right side, normally he should be in hip extension on the right side because he's on the left leg, he's already in initial contact. So you can assume here he is using one of these typical muscle who compensate the lack of posture stability, the hip flexors, and also the knee flexors are a little bit in. And if you look into the foot, and also the toes flexors are typical muscle who compensate the lack of postural stability. So there is evidence that the initial paresis predict spasticity, suggesting that spastic is related to a learned compensation for muscle weakness. So again, spasticity as a compensation strategy for our muscle weakness. Spasticity can, of course, be a cause for contractures after stroke, but weakness is a main contributor to activity limitation. So also you see in elderly publication already that they highlight this point of weakness. For example, plus symptoms, particularly the associated reaction, are increasingly understood as a central nervous system compensatory mechanism in the post-stroke motor reorganization. Associated reactions are stereotypical movement patterns that occur as a result of movements against gravity without proper condition of a normal posture background. And we understand this nowadays as a response from the central nervous system to the loss of posture control in the meaning of reorganization.
As I summarize what I said till now. After a lesion in the central nervous system, the main issue is the weakness, the paresis. So the central nervous system is not able anymore to recruit enough motor units. This is the reason that we have on the opposite side our paresis and our weakness. And this was the cause for this postural instability. Then the central nervous system try to compensate this postural instability in order that I can move somehow against gravity force. So this is the reason that we have this plus spasticity, hypertonicity, with these typical muscles what I was mentioned before. The problem on the structure level is that this hypertone spastic muscle is inhibiting his antagonist. That means the weak muscle become more weaker. This is one problem. The other problem is, as I said before, especially if you see this associated reaction, this is then the new program, this new postural program against gravity force.
Now to the new term spastic movement disorder. There's the same features as the upper motor neuron syndrome, paresis, muscle atrophy, and weakness as a reason for this compensatoric muscle contraction to maintain posture and stability. They have also the feature impaired coordination of muscle activity, altered mechanical properties, and sustained involuntary muscle activation, and all of them are the reason for this compensatoric muscle contraction to maintain posture and stability. What I like with this new term is that they highlight this impaired coordination of muscle activity. And on this, we're looking now more with details. Impaired coordination of muscle activity. That we can perform automatically posture activities, we need the ability to couple motor activity and sensoric outcome, because this is necessary for the internal representation to develop an adequate prediction of the sensoric consequences. The hypothesis is that spasticity is a gradual up-regulation of somatosensoric input. To understand this hypothesis, we have to look a little bit on this system of posture control and how it's organized. For normal movement, we need two systems. The ventromedial system, who has responsibility for posture control. The anatomic structure for this is the brainstem, who provide posture activities. We activate proximal muscles, the muscles from the shoulder girdle towards the elbow and from the hip downwards to the knee. That the brainstem knows in which way they should activate our posture activities, we need this premotor area. This is the anatomic structure where we plan our posture activities. The second system is the dorsolateral system. This is a system who activate selective distally our muscles so that we can move selective. The anatomic structure therefore is our motor homunculus, as you know from your studies. The system works like this. If I want to move my right arm, I need 100 milliseconds before posture stability. So we need a system who provide posture stability before I move. And this is a so-called feed-forward system. As I said it, we need for the feed-forward system the dorsolateral system and the ventromedial system. If I want to move my limb, I have to activate 100 milliseconds before our core muscles and all muscles who are necessary that can hold me against gravity force. Each limb movement means we have a postural displacement and we have to compensate this postural displacement with the accompanying balance strategies. So this is how it works. From each muscle activity, I get a proprioceptive feedback back to the cortex via thalamus. And we can say in an automatic movement, the expected postural displacement can be compensated with preparatory and accompanying balance strategies. And this allowed us to do our fun sport. Here you see how I'm skating, so I need always posture stability before I can move. So this is the reason that we need this feed-forward system that provide always enough posture stability in order that I can keep my balance. Back to the impaired coordination of muscle activity. Here we have two problems: the change in the supraspinal output and the change in the internal representation. At first, the change in the supraspinal output. If you're looking to my colleague here, she's standing like a hemi patient. She's after 5 days in a course, so her cortex is overused and so too weak to control the pathways from the brainstem. Now coming back to the patient, if you're looking on a lesion in the hemisphere, then it looks like this.
As you saw with my colleague, if the cortex is weak, the brainstem is doing what he's able to do. He produces tonus against gravity force without control. On one hand, if your cortex is very exhausted, you stand sometimes like a hemi patient. But this is then also the reason, if we have here the lesion, then we have no contact more between the cortex and the brainstem, and then the brainstem is doing what he's able to do. He's producing tonic activities against gravity force. Flexion in the upper extremity, extension in the lower extremity, and this is a possibility for our hemisphere lesion to stand up, to regain standing and sitting balance, and to walk. Now to this internal representation. As I mentioned before, the internal representation or the body scheme depends on this proprioceptive income. And the hypertone spastic muscle are shouting to the thalamus. That means, for example, if we have this hypertone ellipsoas, the ellipsoas will shout to the thalamus, said, "Hey, here I am." And this weak antagonist is just a little bit whispering to the thalamus. And then the thalamus will only process the information from this loud shouting muscle. Yeah? And this is now the problem for the feed-forward system. That means this information, from this hypertone muscle goes via spinal cord, brainstem to the thalamus. And in this thalamus, we have then only our hypertone muscle there. Yeah, so I make here a plus, so that means the spastic hypertone muscles are present in the thalamus. And that means then this information from this thalamus goes up to, oops, wrong color, it goes up to this sensor homunculus, and then we plan our movement via basal ganglia thalamus, and then from the thalamus to the premotoric area. So we can only plan and pre-activate then the muscles who are present in my internal representation. And this is the reason that our patient then only activating via brainstem the muscles who are existing in the internal representation. And this is then the problem for our patient with the compensation strategy. And one of the hypotheses is then that the central nervous system is increasing to tone to get more information from his muscle groups in order to use this muscle for the feed-forward system.
Now to an example with my patient. We observe at first how she's coming from sit to stand. Let's go shortly that you see it once. And the very interesting part here is that if you observe how she's coming from sit to stand, she's activating her adductors, internal rotators in her right hip, the heel is up, and the toes are in flexion. So she's activating this muscle group which are existing in her body schema or in her internal representation. If you're looking then, if she's coming from stand to sit, it looks almost normal. And then the question is, why it's like this? Now you see she's able to keep the right knee in the alignment. So through standing, in general, we can activate easily our pathways from the brainstem, so it's easier for her to activate her extensors. And now the heel is on the ground, so she gets a clear proprioceptive information from her heel, and this makes it easier for the central system to plan the right muscle activity. Because in the past, or mainly we teach that concentric work is easier than eccentric work. And here we see an example that is opposite like this, because it depends what kind of muscle group existing in your body scheme. The conclusion for therapy is then, of course, on one hand we have to improve functional muscle strength and muscle coordination, but also important is that we optimize the integration of somatosensoric information into the central feed-forward motor program. And here my example with my patient. She is 54 years old. She had an ischemic stroke left with a hemiparesis on the right in October 2018. For assessment and treatment planning, we use in PNF the ICF with its well-known 3 levels: participation level, activity level, and the body structure and body function level. For my patient, means this: she wants, in the daily living situation, she wants to take a shower in standing without fear to fall. On the activity level, she is independent in all ADLs. For short distances, she is able to walk with a crutch. For long distance, she is using a wheelchair. She is not able to use her right arm at all. And from sit to stand, her center of mass was on the left side. She had a medial deviation in the knee on the right side. She showed up with an associated erection, and her heel was up and the toes in flexion. The impairment for me in this treatment session was that she has a weak hip abductors external rotators on the right side. She shows an associated erection, hypertone hip adductors right, and the tricep sure was hypertone, as well the toes flexors. Now, this is sitting before the treatment sessions. I had her 4 times in 4 weeks. We had a break of almost 2 weeks because of COVID. You see how she's sitting. Her left shoulder is up, right shoulder downwards and backwards. The right leg is placed already in internal rotation. And how she is coming from sit to stand. We saw already. We're looking one more time: adduction, internal rotation, and toes in flexion. And how she's sitting down. Now to the treatment planning. Shortly, we're looking what is in evidence-based practice, what we find. Weakness. Here, if you're looking in the publication, they said strengthening and exercising, but it's not described what kind of exercises. Then, for spasticity, standing, weight bearing, positioning, and also exercising. That means, as a summarize for me, for my treatment planning is I have to provide external stability to avoid compensation, so that the patient is able to process proprioceptive stimuli, and for my patient, especially at the heel. Also, I had to improve the stability on the less affected side, because if you remember, she was sitting with the left shoulder up, so this is a sign for me that also the less affected side is not stable enough. Of course, I have to strengthen the hip extensors, abductors, external rotators on the right side, and I have to mobilize her hypertone spastic muscle in order to make them silent. And I have to use the principle of motor learning. At first, for my treatment planning, I know I have to stabilize her in order to minimize the compensation strategies. Because if no compensation strategy is necessary, my patient is able to explore and process the sensoric stimuli, what is necessary to change her body scheme or to change her internal representation, to make it easier to activate via feed-forward system the right muscle activities. So she's lying in side lying. I place blocks behind her. I stabilize with a blanket the shoulder girdle. I was supporting with the pillow the arm, and also through the pillow she gets stability from the front. The hand is at the edge of the table so that she gets a sense of information from the hand. The leg is supported so that compensation is not necessary. Then I start to mobilize at first her right foot towards dorsiflexion and pronation. I use here the tactile stimuli and the technique rhythmic initiation to provide her a better alignment so that she is able to process the sensoric stimulus from her heel in order to activate this ground reaction force, what is necessary to activate enough extension activities. So one more time, and then we looking from above. So I mobilize one more time, specific her foot in dorsiflexion and pronation, so that she's able to process the information, the stimuli, the sensoric stimuli from the heel. This is the beginning. The next step in my treatment is that I want to activate her more. So after I represent the sensoric area of the heel so that she can use the heel to push me backwards, and so I use tactile stimuli, approximation, I use my body for resistance, and I repeat it so that she has the ability in a stable position to activate the right muscle pattern and that she gets the right proprioceptive feedback, what is necessary then again for her feed-forward system. So then she's able to hold this leg, so she's pushing constantly with the heel to me, and then for gradation I use on the opposite sides the leg pattern flexion, abduction, internotation with knee flexion to get more motor units on her right hip extensors, abductors, and externators. Next step in my treatment is to work with my patient in sitting. At first I want to activate her left side to get more stability on this side using the scapular pattern depression posterior. Also through this pattern I activate with the principle of erodation the opposite hip extension, abduction, externation. I arrange the environment in this way that I put a table on the right side to provide through the table more stability. The arm is placed on the base of support and she has a towel in her hand as a proprioceptive information. Here you see it a little more with details, how I use the technique rhythmic initiation. After this, I stabilize with my left hand her right shoulder, and now I use this scapular pattern to facilitate her upper trunk rotation, to facilitate more the transversus and more the hip extensors, abductors on the opposite side, and to mobilize indirectly her pectoralis major on the right side with the principle of changing punctum fixum or mobility. Now I will work further in sitting with the idea to activate more directly her weak hip extensors, abductors and externators, and to give her more the ability to feel and explore her right heel. First, I start with weight bearing to the left side, using the arm pattern flexion, abduction, externation, and the left table is a kind of postural rotation that she knows where she should move her center of mass. Additionally, I ask her now to push down her right heel in order to use the ground direction force to get more her hip extensors and abductors. Next step is for me that I put a towel under her right hip to provide more stability. Remember, we have to provide external stability, that compensation strategy are not necessary. Now, summation of stimuli. One more time, I ask her to keep the tension, meaning I ask her to hold the heel down on the ground. I also resist constantly with the arm pattern. And now the next step in my treatment approach. Now she's sitting symmetrically. I ask her again to push down the heels. I take the upper extremity in my hand so that she gets through my left hand more stability in her right shoulder. to enable an activity in your right hip, or to make it easier for the right hip. Now, my right hand goes on your trunk, on your right side. Here I start with an isometrically resistance and ask her to keep it. Now I increase slowly my resistance with the right hand in the meaning of summation of stimuli, so that she has to push more and more down with her right heel. To mobilize more her reserves, or kind of shaping we can say, I ask her now to move her left arm, but at the same time she has to keep the tension and the activity in her right leg. Now I make it more and more difficult to get more motor units, so I ask her to lift up the arm. Now I start more to work dynamically with her, facilitating leaning forward and backwards, so that she works more eccentrically and concentrically with her hip extensors and abductors. Meanwhile, she has to hold her trunk statically. After this, I bring her right arm in a closed chain, also through this weight bearing to reduce her hypertonicity or spasticity of her wrist flexors. And also here I gradually increase the activity. At first I stabilize the wrist on the chair. I give an approximation through my right hand. I using the scapular pattern depression posterior on the left side in order to facilitate weight bearing to the right. Remember, weight bearing was one of the strategies to reduce spasticity or hypertonicity. To work more with her right shoulder abductors extremitators, I ask her now to move her left arm, because if she's moving her left arm, she has to activate more her right trunk, lateral flexors, and her hip, and her shoulder abductors extremitators. First, one more time, mobilization with the principal changing of punctum fixum and mobility. One more time, a proprioceptive stimuli on her quadriceps to facilitate this ground reaction force. So I use the principle of approximation, push down your right heel. Next step in my treatment is now in a standing position. I use this principle of weight bearing to her right side. I give her postural rotation through my position that I'm sitting at the right side, and between me and her hip are the pillow, so there is no fear for her to move to the right side. I resist with my hands, who are on the opposite side of the pelvis, so through leaning backwards and forward through my body mechanics, I give resistance concentrically, eccentrically. So I'm using the technique combination of isotonics. At the end of my treatment, I use more the principle of motor learning and motor control. This is a part of our philosophy. And now I use with my right hand approximation, and she has a task to move with her paretic arm the chair. This is so what she's able to do. So the arm has a task to move the chair, so she is not able to use the arm for compensation. I try with her to go a little bit from stand to sit to make it more difficult for her, the principle of shaping or mobilizing of reserves. Now, after my treatment with her, she was sitting before. As you remember, her left shoulder was high, right shoulder was low, the right foot was already placed in internal rotation. Now the shoulder girdle is symmetrically, the pelvis is symmetrically, the feet are placed symmetrically. So I can assume she activate a little bit more her extensors and abductors and external rotators in her feed forward system. This was before she was coming from sit to stand, and this is how she's coming now from sit to stand. Still, she's going a little bit in a deduction into rotation with her knee, but the feet stays on the base of support. Now, I was highlighting in my lecture the paralysis and the muscle atrophy and the result that we need this compensation of muscle contraction to maintain posture and stability. I was highlighting also the impaired coordination of muscle activity. As I said at the beginning of my lecture, the topic is too big that I can discuss every point. Also, a huge topic is the altered mechanical properties and this sustained involuntary muscle activation. Conclusion is of my lecture, spasticity is not the reason for the limitation on the activity level. Spasticity is seen nowadays as a compensation strategy to overcome the postural instability. We have to provide functional muscle strength and muscle coordination. Important is to optimize the integration of somatosensoric information into the central feed-forward motor program. And we have to consider and keep in mind the reflex activity depends also on stress, emotion, and inactivity. And all our neurological patients, they are under stress because they has a postural instability, and the postural instability is always stress. Another example I found in the subway, and you see this young lady shows a huge reflex activity, maybe because her telephone call is stressful. In the treatment, you should provide enough external stability using your hands, toes, blocks, in order to minimize the compensation strategy as a requirement that the patient can explore and process your proprioceptive stimuli. What was important to change the representation in the body schema as a base for our feed-forward system.
I hope you enjoyed my lecture, and also, of course, I hope you got some new information and hopefully also some new ideas to treat your patient with a spastic movement disorder. Thanks a lot for your attention. Maybe we see us in the future in some of our IPNFA courses. All this you find on our website. Thanks a lot and bye-bye. See you in the lives